I'm delighted to now welcome one of our Guy's and St Thomas's real kind of royalty here in terms of what they're capable of doing, a kind of a showcase for all that Guy's and St Thomas's do on behalf of both the Institute and for their staff and patients. This is Dr. Ramai Santhirapala. I'm not going to read Ramai's post-nominal letters because they are so extensive that we'll be here till next Thursday. What I am going to be able to tell you is that Dr. Ramai is going to talk about digital pathway redesign to enable early screening, and this is a case study from within Guy's and St Thomas's and all that Ramai is responsible for. So Ramai, if I may hand straight over to you, because people don't want to hear my ramblings, I'm going to let you go straight into it. Thank you very much.
So thanks very much. I think that was a fantastic, it was a very generous introduction, and we also have Jagdeep as well, who's supporting this project as well on behalf of Guy's and St Thomas's. So I just wanted to segue from Joe, who's really given us a brilliant national picture, and to essentially a case study of what we've done at Guy's and St Thomas's within this sphere. So Joe's already kind of touched upon this, but just, looking from the outside in, we have these late identification of quite complex patients, and Jagdeep's going to be speaking about the kind of higher end of complexity there. But we also have to remember that at the heart of this, there is a patient, and, there's a patient that's preparing for surgery, has taken time off, perhaps had carers do similar. And it's really disappointing and a poor patient experience to kind of go through some of the functional obstacles that we sometimes have actually within our preoperative assessment pathways at the moment. And we all know that we've got this elective backlog that changes in numbers, somewhere over the 7 million proportions. And this comes at a time when, if you speak to the frontline workforce, there's a lot of morale and recruitment and retention issues. And I'm coming from this from a kind of Royal College of Anaesthetists Council perspective as well. So there's a real kind of complexities of problems at the moment. And Joe alluded to this, that there's a number of guidance that really impose the value of early screening. So screening patients, ideally digitally led, very early in the pathway. And I'm not going to go through that to any extent because I think Joe's articulated that brilliantly. But what I will add also is that there's a couple of other factors to consider. So obviously there was a Darzi report which spoke about digitalization and how, within the NHS, it's still an aspiration. I mean, sometimes it takes me 20 minutes just to log onto a computer. So, we really need to enable those digital processes. And then in and out is this vogue is the concept of elective hubs. So, specific non-acute sites, so non-acute site hubs where we can actually plan surgeries that are appropriate. So there was just to point to a couple of pieces of national guidance, which is particularly important. So the Centre of Perioperative Care, of which I'm a board member and Jagdeep's the deputy director, released some guidance very recently, actually, around this concept of pre-screening. So really tying in that early concept, but also just remembering that actually even before a patient has seen a surgeon, starting that process. So actually at that first surgical outpatient, we already have a holistic view of who that patient is in front of us. And why is that important? Well, actually, it means that we can streamline those patients who are fit and well. So Joe kind of mentioned the green pathway, and then start to optimize those patients that perhaps need a little bit more input. And this was echoed in the PACE audit, and Joe's gone through this in a huge amount of detail, but just really to emphasize that starting this process early means that actually we can streamline and we can smooth out the patient experience and the patient pathway. And I think from a patient perspective, that's obviously fantastic. But as a clinician who's actually sitting in a clinic myself today, it just mitigates some of the problems that I'm raising and seeing on a daily basis. So, for example, patients who are having surgery in the imminent future and having to essentially work out a plan for them in quite an expedited way. I'll pass on this because Joe's already mentioned, the reasons that surgery is postponed, but effectively it's because of poor planning. So just to reiterate, for those who perhaps are outside the perioperative sphere, this is our surgical pathway as it currently sits. So a patient may go to a general practitioner with a symptom such as knee pain. And then they wait for a surgical outpatient appointment, and they go through essentially a referral process and then a vetting process by the surgeons as to whether that outpatient is appropriate or not. And in the current system, more than likely, a patient is consented for surgery. So, a discussion that surgery is the most viable option happens. And it's that kind of discussion and then the kind of actual setting, the data surgery, that triggers the pre-assessment process. So the setting of the TCI. And Joe mentioned how actually there's a national direction that actually we shouldn't be doing that. And one of the reasons is because it minimizes the amount of time that we have to prepare patients ahead of surgery. So not only kind of, receiving that full holistic view of who that patient is, but actually, implementing changes such as smoking cessation, weight reduction, really simple lifestyle interventions that might actually help the patient post-operatively, so after surgery. So really what we were trying to move towards at Guy's and St Thomas's in this pilot is the concept of early screening. So starting to screen patients, ideally before their first surgical outpatients, although, at the very latest, at the point of the first surgical outpatient. And what does that do? Well, it completely transforms the experience for the patient and also for clinicians and operational teams involved. So not only does a patient, get that screening questionnaire early, so they know that they're in the system, they're being considered, it means that by the time we get to that first surgical outpatients, we already have an overview of, whether that patient's able to be expedited, for example, or what kind of investigations that may be needed. And what it does is it maximizes what's known as that optimization window. So the ability to support a patient and make sure that they're adequately prepared and actually, optimally prepared ahead of surgery. And we know this has impact on outcomes after surgery, as well as improving the patient experience. So what did we do? So we've developed the early screening tool. And at the time of this, so this was when My Planned Care, which came out in March 2023, came out. We started to develop this tool. So we actually looked at various digital supplies and decided that there was nothing de novo. And at that point, although it's a very rapidly evolving field, at that point, the concept of screening was really early on. We looked at 26 preoperative questionnaires, and they were quite detailed questionnaires. So again, that concept of screening really hadn't come through. We liaised with clinical and operational teams, and we also had significant amount of patient co-design. So patients have really driven this project, which is quite unique, I think, to this project. And what we delineated was what's known as discriminatory questions. So which questions do we actually need? So what's the kind of, not so much the minimum, but what's the optimal number of questions that patients, can fill out easily, that we can reduce that clinical risk and identify those patients who can be fast-tracked. And we developed a functional long list and then a short list and then technical requirements, because this is obviously a digital solution. We produced a prototype, tested that, and then went through a feasibility pilot, which I'll go through in a moment, and then iterated to the current impact evaluation that we're doing at the moment. So for our feasibility pilot, so we developed the tool and we're testing it in 4 surgical specialties, so 244 patients in total. And like I said, there was a lot of development into the kind of questions that we needed, and patients really drove that. And it was really brilliant because actually, word for word, we went through every single question. And I think that's borne out in some of the results. And I think, really have to thank our patient groups for that. We had high digital accessibility, so only about 7 of those 244 patients needed support from our clinical nurse specialist who supports this pilot work. We had a rapid response rate, so this was 69% of patients were responding within 24 hours of receipt. And we found that 44% of patients in this particular pilot were able to be fast-tracked. I have to caveat that we chose kind of surgical pathways that were more delineated towards patients that can have same-day surgery, so surgery in a day case or an elective hub. But still, it surprised us to have these figures. I have to say the one aspect is that we did this with a third-party supplier at the moment, very proficient in this, and we obviously have had to rebuild it into Epic. So South East London is now on an Epic system, and we very much follow that principle that obviously, we try and build within our own system first ahead of using third-party suppliers. But still, this was very encouraging for us. And we had an independent analysis. So I have to say all of this analysis was done by the Health Innovation Network, so of South London, so independent. And that was, an aspiration of mine personally. I really wanted to make sure we weren't marking our own homework. But, there was real aspiration that regardless of age, ethnicity or gender, that patients were able to fill out this digital tool. And, a lot of questions always come up about our kind of natural biases towards, digital implementation. And I hope these figures give you some reassurance. So we had a roughly equal split from a gender perspective. But actually, if you look across the ages, you'll see actually that, all these age groups actually perform well in completing the questionnaire. So I think that goes against some of the natural biases that people may have with respect to digital tools, and it just goes to show actually that you have to evaluate, and I would say independently evaluate, because until you do, you just don't know. And that's particularly important, I think, from a digital inclusion perspective. So this is our index of multiple deprivations that we have across South East London. So South East London has got one of the highest index of multiple deprivations within the UK. And again, we just wanted to make sure that the patients involved in the pilot were very reflective of the population that we serve. And you can see from this that they were. So we went into a phase which is Guy's and St Thomas's funded, and this was actually to start to gently disrupt the pathways. So essentially implement early screening into our pathways and have it as the kind of the mode of which patients are prepared ahead of surgery. So we iterated the early screening tool, and this was based on the HIN evaluation. And it was really interesting because there was a few questions about high blood pressure, obesity, airway that just needed some tweaks for patients to understand better so that we can implement the tool better. We developed an evaluation framework, so the HIN have been our continuous evaluation partners, and they're evaluating the current phase of the work as well. We worked with clinical pathways and stakeholders to really start, gently, like I said, disrupting those pathways. So starting to get the tool in very early. Our surgical teams have been fantastic. We developed our patient advisory group. So we had kind of a number of patients come from various groups and actually just formally brought them together. And again, they've really driven this project, and it's been fantastic working with them. And it's really interesting some of the nuances that you learn from listening to them. We rebuilt this tool within my chart. So like I said, we went into an Epic first solution. We developed standard operating procedures, worked with the workflows, and then went live in December. And I have to say, we went live at the time that on the background of, South East London undergoing one of its biggest digital transformation projects. So, again, really have to thank the team for their hard work around that, because it was not easy. We went live in general surgery with two specific pathways. We started with a very phased go live, and I think that also iterates. Actually, there's a lot of anxiety around digital implementation. I think we just wanted to give both patients and clinicians and operational teams an understanding that these pathways are going to be tested and go well. So we did a phased go live with one clinician, and we've onboarded further clinicians since, and we're already starting to see patient benefit. And like I said, formal HIN evaluation will be available later this year, but we're evaluating it in the background just with the data that we can draw down at the moment. And what we're finding, and this kind of speaks to Joe's classifications, is that around 17% of our patients at the moment are deemed what we know as low complexity. And then when we match them to, do they fit the criteria to have surgery on the day? We've got, that flow of pathway, and we've put them onto what's known as a gold pathway, which is very light touch. So they have a swab. They essentially have a swab, and then they can be set for surgery. And actually, that's a really interesting expedited pathway. And we've had patients go from receiving the questionnaire to having their surgery within 14 days on that pathway, which is fantastic. And then the other patients which fall into the cohort of medium high complexity, we've split them into those patients that, again, meet the criteria for same-day surgery and then can go onto a green pathway. In essence, have a very light touch pre-assessment, so not the full process as we know it now, which is fairly complex and lengthy, obviously appropriate for certain patients. So again, they can be fast-tracked of sorts with a light touch pre-assessment. And then the remaining patients, which Jagdeep will speak to in detail, are those patients that do need the workup and do need the full kind of pre-assessment processes. And obviously, that's where POPs have excellent expertise as well. So I'll leave that to Jagdeep to speak further on. What are we seeing so far? So some really kind of early tangible benefits. And this is, for me, I think this is the most interesting, although it's really fantastic to be able to fast track patients. Actually, it's the potential for optimization that personally for me has been really valuable to see. So far, we've referred patients onto smoking cessations, of which, a small number have taken up that opportunity. Again, something perhaps that we can tweak in the process, in the communication to increase that uptake. We've had patients with abnormal blood tests, and they've gone on to have the relevant investigations through their general practitioner. So we referred them signposted them to their general practitioner to have those relevant blood tests. And then onwards, their general practitioner has been able to make diagnosis. So, and further investigations, so an OGD or alcoholic liver disease. We've had patients that, either have had undiagnosed problems such as hypertension or have needed reviews for those chronic health problems. And then we've had patients similarly kind of with heart failure, which perhaps need optimization. And the real kind of win is that you start that process early. And like I said, I'm sat in clinic today, and, the benefits of this to any clinician is obvious. We're doing a HIN evaluation at the moment, and that's going to involve patient experience and patient outcomes. So we're going to do some patient interviews as well, which will be, I think, always delightful to see. I think, it's brilliant just hearing what an impact these processes have. And we've heard informally, particularly from patients who've been on that fast track pathway, how expedient it's been for them. We're looking at things like on-the-day cancellations. We're looking at how well our theatres are utilised and the kind of cost savings from that perspective. We're doing a health economic analysis, and that's going to be threefold, looking at the current impact evaluation and, what's the health economic advantage of that, looking at kind of the projections going forward. So how would we business case this? How would we build the model so that actually it's equitable at the very least? Or from a health economic perspective, cost neutral. And then obviously what's really important is digital inclusion. So we're looking at factors and barriers to that. And what's been really interesting, actually, just looking at the early data. So we've got a digital inclusion rate of just over 10%. But when we break down that data, a lot is to do with the functionalities that we have within our EPIC systems. So, for example, at our trust, we changed the way that we message patients. So we actually said, it goes to their preferred contact, which sometimes could be email. So when our nurse specialist was phoning patients to see if they've, received the questionnaire, they actually said they hadn't, and it's because it's gone to an email address rather than to a simple text message. So just making that flip has changed us back to reverted us to lower digital exclusion rates. So again, that's been quite interesting because it's against the natural bias, particularly for our population, that digital exclusion rates would be high because of actually functional kind of equity reasons. It's not been an easy ride at any point, really, but actually it's been fantastic just to learn from the whole process. And actually, not having a clear innovation pathway is something that's become quite obvious to us, and that's something that we're building on. And that's common to the NHS. Aligning kind of to the trust strategic alignment and certain priorities and looking at the bigger picture, I think at the NHS, particularly in the current context when there's uncertainties, obviously at a national and policy level, it's trying to align with them. The kind of, the changing landscape has been an interesting exercise, let's say. And I think, again, you can learn from that. Finding the right team members. I have a fantastic team behind this, and as some of you will know, so a brilliant program manager, our nurse specialist, Lepalele, is very unique. And actually taking time to find those right team members is again, a process, but absolutely formidable going forward. As a clinician, it was really interesting working with third parties. It's not something I personally had any experience of prior, and actually it's quite interesting because it's just two-way learning through the whole process, and actually just maintaining momentum. So again, lots of complexities. We've had kind of industrial action. Obviously, thankfully that's in the past now. We've had lots of kind of complexities that have added to this, but actually even more so to me, it makes complete sense to have what Joe described, those bank of patients that can have their surgery that are cleared. So just to say big thanks to kind of Guy's and St Thomas's charity, obviously, for funding this work. My own directorate in cancer and surgery, who we sit under, those across South East London who have supported this work as well. Health Innovation Network, who continue to be our evaluation partners. Apollo, who are kind of our EPIC partners and helped us immensely with rebuilding the tool, and our Centre for Innovation, Technology and Improvement, who've really provided some of the horsepower behind this as well. And just to kind of nicely segue into, we're in discussions with Jagdeep as Deputy Director, and also the other Deputy Director, Scarlett, with the Centre of Perioperative Care about, what are the next steps. We will have a HIN evaluation, like I said, later this year, and to really start to embed this practice and also start to spread this practice to those who, to relevant kind of trusts and networks that, want to adopt early screening.
Oh, goodness me, Jagdeep's in trouble here because we've had two absolutely star-studded presentations so far. Will Jagdeep make it a triple crown? Let's hope so. Ramai, that was magnificent. Thank you so much. I love the detail that you went into. I love that, as other people have commented, love the focus that you brought in on the patient. I love the fact you're doing follow-up interviews with the patients and so on, rather than just making this purely clinically centric. Would anybody like to ask Ramai a question or offer an opinion? Oh, Joe would like to ask a question, I think. Go ahead, Joe. Thank you.
I mean, everyone may have heard my voice too much already, but I've got a couple of questions. But I think, first of all, Ramai, it's just that's a brilliant example of how to implement early screening, and I think the patient involvement's fantastic. The involvement of external evaluation is really great, because not only is that useful to support your work, but it will help other trusts evidence what they want to do, which I think is going to be really helpful. I was interested that you look at some patients before they come to their outpatient appointment, so presumably some of them may not go ahead with surgery. Does that increase your workload quite a lot?
So that's a really interesting question, Joe, and Jagdeep and I have spoken at CPOC Exec about this as well when we presented to Jagdeep and colleagues there. It's really interesting. So we picked pathways that we know have a high conversion rate, so inguinal hernia, cholecystectomy. I have to say, and this is a learning for me, is that I obviously come from a perioperative lens, and I think all population health interventions are useful from a patient perspective. So picking something up in a patient who doesn't ultimately have surgery. And as most of you know, I am a shared decision-making enthusiast, and I think, it's as much of a impact to support a patient in the decision of not having surgery as it is to proceeding with surgery. I also think, that's also of benefit to patients. However, having said that, from an operational perspective, we've deliberately chosen pathways that have a high conversion rate. So, over kind of 80% conversion rate to surgery. Going forward, we probably will do it at the first surgical outpatient, just from a practicality perspective, because I don't think there's quite the operational buy-in yet for the wider population health argument. But that's not to say that it's not important, and I do think we should aspire for that in time. Because I think any new diagnosis, any new hypertension, diabetes, etc., that's picked up and can be followed up because they're screened with a potential intervention, whether that intervention goes ahead or not, I think ultimately in time, I would hope that we'd have a healthcare system that actually wants to screen patients because they want preventative care.
Thank you. That's really helpful. And just sort of linking into that, did you involve primary care in the setting up of your screening? Because presumably when all these things are being picked up, a lot of them are going to be sent, a lot of these diagnoses that you mentioned on the list of things that you found are going to be sent back to primary care to manage.
So yes, we did, and our nurse specialists signposts to primary care at the moment as well. And you know what is really interesting, and this is a sneak peek, because obviously they're here doing the evaluation concurrently to our impact evaluation. So our nurse specialist who sits in secondary care instigates some of the, optimization that needs within secondary care. So might order an echo, for example, or might order, iron studies because of a pickup of anemia. And what's really interesting, and we're looking at the kind of primary care versus secondary care interventions, and actually, understandably, because our primary care colleagues are, kind of somewhat overwhelmed at the moment, it's really interesting that actually the primary care pathways at the moment, perhaps don't support early screening to the extent that we'd want them to. And that's no disrespect to our GP colleagues, because I think they're amazing. And, one of my best friends is a GPs, but I just don't think we're set up from an operational perspective from that aspect. So it's really interesting. So I do think the early screening model sits in secondary care, and I think we have to find a way to model what that early screening nurse, if that's the role that evolves, that certainly from our modelling looks like the role that's evolving, can do within the remit within secondary care.
Yeah, thank you.
All right, let's. We're going to have to end it there. But Ramai, thank you so much. Box office, you've got the job. Congratulations.
I think you've got the star next, so I will go.
Well, we shall see. She's under a bit of pressure now,